If you have any objections, you may disconnect at this time. I will now turn the conference over to HHS TV. Thank you.
Hello, and thank you for joining us today. This is an on-the-record media briefing with HHS Assistant Secretary for Health, Admiral Giroir. Admiral Giroir will give an update on the national testing strategy, then we'll open it up for a question and answer session for members of the media. For the Q&A, please state your name and media outlet before your question. At this time, I would like to hand the briefing over to Admiral Giroir.
Good afternoon and good morning to those of you who are not on the East Coast. I want to start by saying my team and I seriously considered postponing or canceling this briefing today. My office window overlooks the Capitol, and we saw firsthand the appalling and shocking events and are really personally touched by the loss of life. Walking out of the door, there were 3 flashbangs going off. Helicopters overhead, sirens, a truly surreal sight that I hope I would have never seen. But at the same time yesterday, we had another reality, and that is almost 4,000 Americans died of COVID. And we are in the fight of our lives for Americans in this country and for people around the world. And thus I wanted to continue this briefing, have it today, and I appreciate all of you attending. I have greatly appreciated our time together during the media calls over the past truly 10 months. I've found them informative to me with your questions. I hope you found them similarly informative. And I hope you understand that I have been completely transparent with the information we have discussed. And I do believe, even though we've kept all our boundaries intact, that we have worked together in a productive way to improve communications to the American people. We're going to do something a little different today and conduct a video live stream to help better illustrate some of our principles and policies, what we have done, and more importantly, where we're going as a nation. When you put aside all the political rhetoric and oversimplifications of the issues, I think all Americans should be proud of the development and rapid scale-up of our COVID-19 testing. To be sure, there were significant challenges and setbacks at the onset of our response. But where we are now is a testament to our resolve as a nation, the strength and vitality of our academic, technological, and industrial base, and the ability of the administration to mobilize and execute a flexible, evolving, and dynamic national coronavirus testing strategy. Has it been perfect? Well, of course not. Has it been highly effective in saving lives during this unprecedented global threat? Yes, I am absolutely convinced it has been. As we transition to the next administration, I am sincerely confident that we have built together a solid foundation upon which to keep building. Let me start with some of our overriding principles and directions. The national testing strategy is not just a single document, but several documents, and it's a live, dynamic document. We started with the strategy on April 16th with the testing blueprint delivered by the White House Task Force in the Rose Garden. On May 24th, my testing and diagnostics group delivered a very impactful, very specific plan to Congress, the COVID-19 Strategic Testing Plan report, which was literally hundreds of pages of detailed information. The blueprint was addended in June, and we updated the plans in both August and November. And I invite all of you to go pull this information. They're all publicly available, and look specifically at what we placed. In addition to these, though, very importantly, testing guidance is updated regularly by the CDC, almost weekly, by the CDC, by the task force, and us. These are all sort of tactical pieces to the overall national testing strategy to help states, communities, localities, physicians, nurses, public health specialists really implement in a very specific way the national testing strategy. What are the objectives? The objectives have stayed the same over the course of this pandemic. First is to rapidly diagnose hospitalized patients, very important. And just recently, there's also an imperative to diagnose those eligible for authorized or approved therapies. For example, monoclonal antibodies. It's very important to diagnose particularly the elderly and the frail early in the course of their illness, get them infused with monoclonal antibodies, because we know that could decrease by as much as 70% their chances of hospitalization and death. But you have to have the diagnosis early before you're even very sick. Secondly, we absolutely need to find cases among persons who are symptomatic, those who are exposed under contact tracing, and those who are otherwise at risk regardless of symptoms, whether they're in universities, whether they've been in crowded places, or whether they've undergone travel. And this has been a very significant emphasis of the national plan over the past several months. Recognize newly emergent outbreaks. It's very important, and we know the sequence, and you've heard them many times. When the percent positivity starts going up in a locality, we can be sure, you could bet your life on it, and it's very serious and lives do depend on it, that when those positivity cases go up, then cases will go up, emergency room visits will follow, hospitalizations will follow, and after that, mortality will unfortunately follow. So being able to get that signal very early allows us to surge testing sites, to surge therapeutics, and often to surge personnel in the public health service, for example, and also our DoD and NDMS colleagues. Protecting the vulnerable. We know since very early that as much as 40% of our mortality, particularly early in the pandemic, were localized to people who were in nursing homes. We know that people over 75 are at the highest risk, people of any age who have comorbid conditions, and particularly our racial and ethnic minorities. So it is vital to protect them. And as we go on with this briefing, I'll show you exactly how we've tried and succeeded in doing that. Facilitation of safe opening of schools and businesses. This has been a priority from the start. And we are now achieving the kinds of tools and techniques, and we have the partnerships to make sure that even though schools are safe now and they're not a spot for transmission, we're going to make them even safer moving forward so that parents, grandparents, teachers, and everyone involved have the absolute confidence to do the right thing, and that is to get children back physically present in school. And finally, to enable the state testing plans. The states have never been on their own. The states are independently funded, but they take guidance. Their plans must be approved by us. There is literally 24/7 availability to work with the states, the local communities, on how to develop, strategize, implement, change, and monitor their testing plans. This is a major function of my group, and it ongoes every single day. To achieve these principles, there were technical principles of the national testing strategy that we continue to work on, implement, and evolve. The first is simply to build capacity of test and collection infrastructure. As I've told you before, on March 12th, when I was designated the HHS lead, there was not a single tube of media, a single swab, or a single test in the stockpile. This was a virus that had never been on the planet before, and tests needed to be developed. Now, at first, we only had a single type of test, and I'll go over that very shortly. So we needed to innovate to increase the diversity of tests and platforms. Point-of-care tests don't arise by themselves. They often take many years, often a decade to happen, and we needed to shrink that timetable into 4, 5, 6 months. Now, testing is not just a scientific endeavor. It's not just a public health endeavor. It's a regulatory and reimbursement endeavor. And that's why we needed to co-evolve regulations by the FDA and the CMS and regulatory strategy and the guidance from the CDC to meet the stage of the pandemic. We're in a different place now than we were in July, and a far different place than we were in March. And the capabilities and needs of the testing ecosystem. We would have loved to have 100 million tests in March. We had less than a few million. We would have loved to have point of care in April, but we only had one, and we could not disseminate that because it was a moderate complexity test that required an instrument. So we evolve everything that we do with the reality of the testing ecosystem and the regulatory and financial environment. We needed to expand the industrial base to increase testing capacity, and that is the most important point where we are right now. We have diverse technologies, we have a robust ecosystem, but we need to continue to push, as we are, to advance the industrial base. And finally, to understand the interdependencies of the U.S. and global supply chain. Many tests rely on a single point of failure. That single point of failure cannot be tolerated, and it's often overseas. So this has been a major part of the national testing plan to not only to develop the technology, but to do the work. And our DoD colleagues have really been on point on this, the Air Force, the Army, the Navy, the Coast Guard, working as they do so well into securing the supply chains, because that's what they do to supply our armed forces on a daily basis. Now, I don't want to go over this entire slide, but there is a rich infrastructure of the interdepartment and the interagency in three major segments. First is the development programs. That's to develop the technology. And we have organizations like DARPA, my former organization, the Department of Defense, who are doing very high risk, very high yield work that's translating into capabilities that actually we're now using today. We have the NIH with billions of dollars of investment in the Institute of Bioengineering and others to develop novel tests emphasizing point of care. The CDC for things like wastewater surveillance, and the Biomedical Advanced Research and Development Authority here at HHS. Their full-time job is to develop countermeasures, including testing, and much of what we have today rests on their shoulders that they've been developing over the past decade. The scaling programs, there's a scaling program at NIH called RADx ATP. My testing and diagnostics work group has invested billions of dollars into scaling these programs based on the technology developed in the first column. DoD commercial solutions openings, they're called CSOs, or areas of interest. Again, billions of dollars of investments working through the DoD procurement, all part of this ecosystem. And finally, the Defense Production Act, both investments and rated orders. Investments are where most of it comes, actually using that to invest in industries, but also to rate orders so they're first in line, and I will go over that soon. Implementation programs, from the high risk to the lower risk. We have pilot programs for strategic surveillance and for K through 12 schools, and I'll talk about that shortly. We have programs, RADx Up and Office of Minority Health, focused on specific strategies to implement and to get acceptance of testing in minority and underserved ethnic communities, including Native American communities. Our community-based and surge testing sites. We started on March 12th. By March 18th, we had our first drive-through site. We put up 41. Now there are over 7,600 community-based and surge testing sites around the country. And finally, those state testing plans. The states received $11 billion, and I announced another $19 billion to the states to implement their plans at a state, local, and community level. But we are absolutely involved on a daily basis, especially the CDC, with how these plans go, how they evolve, how we monitor them, and how to improve them. So let me go over sort of a few phases, the progression of testing according to the National Testing Strategy. And these are overlapping, but I want to bring you chronologically through them. When we started, there were only laboratory-based molecular tests that really required high sophisticated laboratories, only a few available in the country, and that was sort of epitomized by the first CDC test that came out shortly after the sequences were published from China. These were followed by what's called LDTs, Laboratory Developed Tests. These are the tests that form the foundation for labs like Quest and LabCorp and many academic and highly sophisticated hospital laboratories that developed their own tests to diagnose. Then came the incredible surge of commercial manufacturers, the Thermo Fishers of the world, the Cepheids, the Hologic, that put together kits. These are sort of all-in-one Happy Meals that provide all the reagents, everything that a laboratory needs to do, and can supply them in millions of quantities per month. This made testing much more broadly available. And finally, just recently, although it's laboratory-based sophisticated tests, there are now home collection. So even though it goes to a laboratory, you get sent a swab or a tube at home, you put it in the you collect it, you put it in the mail, in 48 hours you get your results. The next big advance was the point-of-care molecular and antigen test. This really is where we wanted to go, to get closer and closer to patients so that you know within 15 minutes whether you're positive or negative, and we can take actions right on the spot. The first one to the market was Abbott ID Now. It's a sophisticated molecular instrument. It is low throughput, but it was authorized in mid-April. We purchased 40% of the global supply and distributed them and have continued to distribute those to all the public health labs throughout the country, with a special emphasis on those states that have high geographic challenges, like Alaska and Montana, and also to our tribal nations because of the great span of territories that they have to deal with. This was a tremendous advance early on. That was not followed on until the midsummer, late summer, with the Quidel Sofia and BD Veritor. These are antigen-based tests, but they require an instrument. So it's not something you could do at home and not something you can do everywhere. We used the DPA to take the entire supply of these tests to supply all the nursing homes in the country so we could protect the vulnerable, not only testing the residents, but more importantly, testing the staff. Because remember, the staff brings in the infection into the nursing home, not intentionally. We know that this is an asymptomatic disease in most of our cases. So it's critical to test them once, twice a week in order to protect the seniors. And most recently, as I announced in the Rose Garden, as all of you remember me swabbing myself, the Abbott Binax Now, the card-based test. We purchased these 150 million, the first 150 million, and distributed those to the vulnerable and to states. This was a tremendous advance, a very sophisticated test in a card-based form for only $5 and 15-minute results. The next phase is really where we are right now and are trying to scale, and that is not just home collection, but home testing, where individuals can conduct the test within their home. There have been several advances, and I just want to show you a few of them. The Lucira test was the first home-based test to be authorized, and it's really quite amazing. This is the Lucira test. It comes as a swab because a swab needs to be done in your nose, like almost all of these tests. Only a few do not use that. The swab deposits the material into this tube of media. This is pressed down on this device, and this is a very sophisticated nucleic acid amplification test. You press it down, you see the lights blinking. It even comes with batteries, and within 15 minutes you have a result, and it turns up either positive or negative. A highly sophisticated test. These are not widespread. They're still in low quantities, and they still require a prescription. The second test, which is soon coming on the market, is the home version of the Binax Now test. It comes in this nifty box. It does require a prescription. There is a telemedicine proctor that helps you through it, but it's the same test that I just showed you with the Binax card, except it's much easier to do and it's a single use. It, of course, requires a prescription. The third test, which was just recently authorized, is the first test that is over the counter. That means in very limited quantities, starting in just a couple of weeks, but rapidly scaling over the next few months, you will be able to go into a pharmacy, buy the test, and perform it at home. Now, it has a few components. This is a very sophisticated system that does the test in an all-in-one form, and we're very excited about this because we know the company is developing flu tests and other things that could be done at home. It comes with its own swab. It looks a little different, and I'm showing it to you here. This very short swab, if you're a child, this little orange guard is there to make sure you don't push it too far up your nose. If you're not a child, the orange guard comes off, so you can get it to, quote, the mid-turbinate. It's not all the way back, but it's partial of the way back. Once you get the sample, there is some solution. You screw this in. You pop the cap. You put drops in this device after turning it on, and within 15 minutes, this device will send the result to your iPhone or other phone app, and you have it. Very highly sensitive, very highly specific, again, in very limited quantities, but a major technological advance that we are going to leverage fully as we move to more home testing, and particularly getting children with full assurance to back in school and people back to work. Where have we come? Well, we are now over 250 million tests reported, with 9 days of over 2 million tests performed in those days. And let me just be quite upfront. We believe the actual number is probably 330, 340, 350 million, but we know that point-of-care tests are not routinely reported. In fact, only a small minority of them are. While we are working with states and communities to get that reporting up, it's much more important that the tests are done and that infections are identified and people can isolate or get sent to therapy. That's the #1 priority. So even though we're not getting those reported, we know that they're reporting the cases that result from them and people are getting tested, and that's what we want. So 250 million in the books, but probably well over 300 million that we've performed. Where are we going? This is a projection slide. I have an entire team of individuals. Most are from the DoD, some are from NIH, many are from CDC, that work on a literally daily basis with all our manufacturers and industrial partners to know exactly what they're going to be producing over the next several months, what their supply chain needs are, and how we can help fulfill them and ramp up production. These are our projections over the next several months, and it's divided in point of care versus laboratory based. And you'll see that over time, that green point of care, whether it's antigen or molecular, is dominating the space. And that's great because they're less expensive, they're incredibly effective at identifying those who are infectious to other people, and they can get to you right where you are with results within 15 minutes. We'll have 170 million available in January, over 250 million available in April. And this is not counting pooled testing, because those laboratory-based tests can be pooled, so that number could be amplified. And it doesn't assume any more EUAs, any more authorizations. We know there will be more authorizations, but this is really a sure thing that both our administration and the next administration can plan for and understand how to best use these within the ecosystems and the challenges that we have. So let's do some of the top-line numbers. Direct support to states. Remember, public health is a local challenge. It is now, it has always been. The primary function of the CDC is to support local public health. And that's why Congress has appropriated and the President has signed, including the most recent bill, over $30 billion directly to states, territories, and tribes, strictly for testing. Now still, only about $1.5 billion of the first $11 billion has been used. But we are working with states to make sure they expense their funds, they develop the capabilities and capacities based on the tremendous technology we've developed and the infrastructure at the national level. We've sent $20 billion to nursing homes. Now that's not just for testing, but it's for other needs. But nursing homes have significant resources now to do their testing. If you're uninsured, HRSA can supply funding to those people who've tested you. They've done almost $1.3 billion in funding. In terms of those swabs and media that were nowhere to be found, not in the United States, and we were sending C-17s over to Italy and other countries very early, we have now built the industrial capacity. We have sent 182 million swabs to states, 225 million tubes of transport media, and we continue that program. What the states need, they order and we send. That ID Now molecular test, that first one that was authorized in April, 4.3 million tests have been sent around the country. And it's not just that. There's continuous technical assistance and reviews of the state plans by the CDC and my testing and diagnostics working group. This is an ongoing, dynamic living process. How do we protect the vulnerable? I told you we use the DPA to buy those instruments from BD and Quidel, and 15,300 nursing homes, that's every single nursing home in this country, by mid-September, every nursing home that could function as a lab, there are only a few hundred that can't, received point-of-care instruments and 5.3 million point-of-care tests. That saved thousands, if not tens of thousands of lives. We followed that on with the next innovation. That was that Binax Now rapid antigen card, and I'll show it to you again. We have sent almost 50 million of these to nursing homes, but also to assisted living, to hospices, to some independent living centers to protect the elderly. We've also sent them to historically black colleges and universities because of their high risk and the high risk of their families. We've sent them to tribal nations, and we've also used them in disaster relief settings, primarily hurricanes on the Gulf Coast. These are all reinforced by CMS guidelines, favorable reimbursement policies, standards, and inspections. There's continuous CDC guidance and considerations, and even in the Public Health Service has sent strike teams to dozens of nursing homes to help them not only with testing, but just care. And remember, we were in Seattle in that first nursing home in Kirkland. My officers there for over a month to provide care when the care staff could no longer provide it. We continue that kind of work. For strategic surveillance and opening of schools and businesses, we've sent over 94 million of those Binax cards to governors and state health officials that they could use as they see fit. We highly advise them to use them to support school openings, keeping schools open, but also critical infrastructure. Many have used them to support prison testing. They've done a great job utilizing these, and very shortly we are going to have a system in place that the governors can purchase these on the GSA schedule over the internet for $5 a test so that they can meet their needs. We've been talking about K through 12 school testings for a long period of time. It has been something we want to do. Now I want to emphasize, data continues to show that schools are safe for children to attend. There is very little transmission child to child while in school, and in fact recent studies published in the MMWR show that of all the places kids get positive tests, getting positive from going to school is not one of them. That being said, we want to make sure that we can supplement the current safe school environment with tests that are needed. That's why on October 1st, not November, December, or January, on October 1st, we signed an MOU with the Rockefeller Foundation and are doing pilot testing sites in the cities you see here, in Louisville, in Los Angeles, New Orleans, Tulsa, Rhode Island, and the District of Columbia, using our Binax cards and other layers of testing in a test situation to know how we can best disseminate and scale this kind of testing throughout the country. We also have surveillance programs that are not with the Rockefeller. Most are just among communities that we do repeat serial testing, much like you hear all the time by our colleagues like Professor Minna talking about we should be doing. But we're also doing pilot programs, exciting ones, through CHOP, the Children's Hospital of Pennsylvania, and Seattle Children's Hospital in both Pennsylvania and Washington. Washington is new. Pennsylvania is rocking and rolling throughout southeastern Pennsylvania, where we're going to have serial testing every week, asymptomatic, of school children and teachers, and understand, do they add value? Do they cause problems? And if they do work, how do we best do this on a national level? We also have, right now being stood up, a massive home testing pilot where we're going to use some of these tests and some others not yet authorized, led by the NIH with numerous academic and private sector partners, to really test on using millions of tests. Does home testing really help? Or does it potentially hurt? If you get a false positive and you're not sick and you're positive, does that mean you stay home for work for 2 weeks? What if the false positive rate is 2%? If you test 100 million people, that's 2 million people every week out of work for 14 days. How do you really implement this in a way that is helpful and not harmful? It is not obvious that this will be helpful. It could be helpful, but we need to test it now that we have the tools, and that's exactly what we're doing. I won't go over this in detail, but we've invested in the upper left corner billions of dollars in research and development from the NIH, from BARDA, from our DoD colleagues. We have enabled testing sites. This is in the community. Over 1,300, 95% of our federally qualified health centers under HRSA are conducting testing. Over 7,600 community sites in our retail sites. We have gone to 644 surge sites. This is what we're doing now. When you're having an outbreak, we send a surge site. We send full medical teams, full testing capability to do thousands a day. We've done 644 of these in 23 states. You talk about DPA, we've used DPA rated orders in your upper right-hand corner 13 times, moving our programs to the front of the line. We've sent 41 747 equivalent air bridge flights from all over the world to bring things like swabs and media, but now pipette tips, which are in short supply. We've done 309 emergency use authorizations for tests, including these 3 at-home tests, but 32 for home collection. And at the bottom right, literally billions of dollars of ongoing investment in acquisition, in development programs, primarily from my office, from the DOD, and from the Assistant Secretary of Preparedness and Response. I want to close by making a couple of announcements that are very exciting to us. Today I'm announcing a continuation of our community-based testing program. This is what I just talked about. We have 2,800 live sites in retail partners. This is Walgreens, CVS, Rite Aid, Walmart, in a number of independents. They're live in 50 states of DC and Puerto Rico. By design, 65% of these are in communities of high social vulnerability. We're adding an extra $550 million to this program, announced today. There will soon be a press release that will keep these sites operational through early April 2021. These have been phenomenal success stories, bringing testing to the neighborhoods, no questions asked, don't need symptoms. You could be asymptomatic, at risk, at low risk. We test you, no questions asked. The results are back within 48 hours, if not point of care. The second program, we're adding another $300 million to the point of care testing program that I talked about. The first 150 million Binacs will have been distributed by this week. I previously announced we're adding 30 million test extension to that for the vulnerable, the HBCUs, tribes, and our pilot programs. We have now received another approval for $300 million for another 60 million additional Binacs now, or equivalent technologies as they come on to further that program. So finally, I just want to close by again thanking you, thanking all of you for what we've been able to discuss, communicate, improve nationally over the past 10 months. I will be, of course, leaving my position on January 19th. I am actively involved with the Biden transition team at all levels to make sure there's a smooth, professional, and seamless transition so we continue to build a vital and important testing structure to save American lives and restore the future of our country. With that, I'll be very happy to take your questions.
If you would like to ask a question at this time, please press *1 on your phone, unmute your line, and record your name and media outlet, as it will be required to introduce you. Again, to ask a question, please press *1. Our first question comes from David Lim with Politico. Go ahead, please. Your line is open.
Hi. Thanks for holding these calls on such a regular basis during the whole pandemic. I appreciate it. My question today is in regards to the curative test that FDA issued a safety communication for. My question is if you have details that you can share about the performance of the test and your understanding of if it can still be used in the cities that it's being used to still test people in with confidence, especially for asymptomatic individuals where it's not on label. And in addition, in the U.S. Capitol, where it's being used to screen members of Congress for COVID in light of the protests and the riots yesterday on Capitol grounds.
David, thank you, and I'm glad you're batting 100% as being the first question on all these times. I know I could start off with a really solid question. So I think the FDA communication about curative really said it all and said it specifically. I reviewed it beforehand and certainly agree with that. What it basically said is you need to use it on label, meaning for symptomatics within the first 14 days, and that there were potential performance issues, including false negatives, if it were not used on label. This is specifically applied to the curative test and the curative technology, and I really have nothing else to add except that I would urge that to be used in its on label. We are always open to new data from curative to show that they can be effective in other situations. But right now, my colleagues at the FDA have made the conclusion that it really needs to be used on label. For the second question, I'm not at liberty to go in great detail, but we have made and are working with the Office of the Congressional Physician very closely to provide high throughput, very sensitive testing that would not be dependent on curative, and we are very confident that will be in place to handle all the issues around inauguration. Again, we have developed this very rich ecosystem. We have a number of choices, and we're exercising several of them. We have a plan A, which will work. We have a plan B and a plan C, each of which could independently work, but layered levels of security. So I am highly confident that we could meet the security needs of Congress, and particularly with a number of individuals coming to the inauguration. Thank you for that. Very good question. Next question.
With that,
Our next question comes from Emma Court with Bloomberg News. Go ahead, please. Your line is open.
Hi. Just wanted to echo what David said about how these regular briefings have been very helpful, and we've really appreciated your willingness to walk us through all the science. I was hoping you could speak a little bit about vaccine rollout and how it might, relate to testing sites. We've seen some counties, for instance, say they're turning testing sites into vaccine sites, and one can imagine with limited resources, vaccine rollout will be more of a priority than testing for many public health departments. Should we be concerned about this moving forward? I'm curious if you're seeing any evidence of that already happening, if there are any resources in play to ensure testing doesn't get kind of put on the back burner or become more of a problem.
So thank you for that. We have certainly heard of communities that are sort of combining in a great way testing with vaccines or going to monoclonals, and I think this is very important. If someone comes for a test, if they're positive and if they're at risk, they go immediately to a monoclonal infusion. If they're negative, they go to a vaccine site. I have not heard of any trade-offs, like people closing sites in order to, closing testing sites in order to do vaccines. I would not imagine that will be the case in the overwhelming majority. Again, there's been a bump up of billions of dollars to support the states in vaccine rollout. That's just recently happened, as well as, of course, our contracts with 19 pharmacy chains to support that. In terms of the vaccine rollout, I don't want to focus too much on here, although I frequently speak about it at all other efforts. I think what you've seen is that phase 1A, where you're dealing with healthcare institutions and the nursing homes. The nursing homes vaccines will be gone up dramatically this week and next week, as enough vaccine gets there and enough nursing homes can get all their consents and logistics done. Where I think the vaccine will really take off, and where I really urge governors to go, is to really go into the populations at risk, the 65 and older populations. This is where you get the massive scale, when you can get to the about 40,000 retail sites that will provide vaccinations across the country. They're, of course, not useful if you're just vaccinating a few nursing homes and healthcare providers, but as they get put into force, like being done in West Virginia, like being done in Texas and Florida, that's when you're going to see the massive number of vaccines there. As we all know, vaccines on the shelf or in a FedEx box are of no use. They need to get in people's arms, and that's our number one focus, because that will end the pandemic. And let me just take this opportunity to again say, we can save tens of thousands of lives over the next few weeks if we wear a mask, we avoid crowds, we avoid indoor crowded spaces, we wash our hands, do those simple mitigation steps. But it's really vital. Again, we lost 3,844 Americans yesterday. And although some of the trends with the number of cases are going down in many parts of the country, the hospitalizations are still high, the deaths are still high, and we know those are going to lag. So we need to double down while we do vaccines on the things that we know. Look, we can save tens of thousands of lives just by doing something simple. I really urge all of us to continue doing that as universally as we can when we cannot physically distance. Maybe next question. Thank you, Emma. I've enjoyed your questions very much as well. You've been great, and your stories have been really high quality. Appreciate that.
Our next question comes from Dan Vergano with BuzzFeed News. Go ahead, please. Your line is open.
Thank you. Dan Vergano of BuzzFeed News. Admiral, I wonder if you have anything to say about the reports of these variants identified in the UK and South Africa. There's been some criticism the national testing strategy should have included genomic analysis to pick those sort of things up in the U.S. And what can or should we be doing looking ahead to pick up these kind of variants or strains?
So I was just going to say my domain of the testing strategy is really clinical diagnosis, surveillance testing, screening testing. The CDC has really run the program for genomics, which is really not a clinical test. That's really a surveillance at a very high level CDC, and they've had an ongoing program. And Dr. Redfield has talked to you about that, and I think you know that they've scaled that up pretty dramatically. I want to assure the American people of a couple of things. Although a couple of our tests are affected by the strains, you will still be able to get diagnosed even by those tests. The most notable one is the Thermo Fisher product, and we're using this to our advantage. It has a dropout of one signal in that spike protein gene, so it becomes negative with that deletion variant, but it's still positive because there are multiple other targets. So great design by Thermo Fisher. But you can be confident that our diagnostics, if you are sick with a variant strain, you will get diagnosed and be eligible for treatment. Secondly, we still do believe, and there's increasing evidence for, although not 100% proven, that the vaccines will work against these variant strains. Now, we do know that they're in the United States. There have been multiple states. We know that they're not widespread. In other words, they don't account for a majority or even a significant minority of our cases. But we do believe they're out there, and they may have even arisen independently in our country because viral evolution tends to converge to where the most fit species are. So they are there. We need to be cognizant of them because they can transmit more easily, even more of a reason to wear a mask. And I'm confident that the CDC, together with their private partners in the NIH, will increase their full sequencing activities, which are not clinical testing, in order to detect these variants, but other variants. And I think Ambassador Birx has said, it's entirely possible, and we would expect other variants to be in the population after this is circulated for many months. Next question.
Thank you.
Our next question comes from Matt Perrone with AP. Go ahead, please. Your line is open.
Hi, Admiral. Thanks for taking questions and for all this valuable information. I'd seen, I think you were speaking last month at American Clinical Chemistry Council, but you mentioned the idea that the PCR test, I think you called it a biased or imperfect gold standard, and many people are still saying, PCR is the gold standard. I wonder, that's an idea we've heard from academics, from people outside government, but could you expand on that in your own words a little bit about the shortcomings of PCR?
There is no such thing as a perfect test, and I've said that many times. Tests need to be used in the right way, the right test for the right person at the right time. PCR is not the gold standard. It is the first standard we have, if you remember that chart, because that's what we sort of rely on as our basis for molecular diagnosis. What PCR does not give you a good idea of is infectiousness, okay? So we know that people can be positive by PCR, which amplifies 2 to the 35th, 2 to the 40th, 2 to the 45th. So even if you have a very small remnant of viral RNA in your nose, it's going to pick that up and you're going to be positive. And we know people can be positive weeks or even months after their overinfection and no longer infectious. So that's just true. That's the way it is. Antigen test will not, like the Binax card that we've talked about, like this Binax card, it will not pick you up as positive when you have very low levels that are not infectious. So it is very true that you could be negative by Binax or negative by Illum and positive by PCR. But what the antigen tests tell you is, are you infectious to other people with a very high likelihood? We cannot get trapped into the scenario, and I'm going to do my best Mike Minna impression here. We talk all the time. We're not 100% aligned, but pretty close. What we really want to know is who's infectious and to get them out of the population so they can't transmit it to other people. And simple antigen tests that are low cost and high volume do that extraordinarily well. And we cannot get trapped into saying they're not the gold standard PCR. Of course they're not. They're a different type of test. But for public health, for finding who's infectious, They work extraordinarily well, and they will be the backbone of our system. That doesn't mean PCR is bad. It's very, very good. It's highly sensitive. It is the foundation of our, third tier kind of quaternary referral structure for laboratories. It is absolutely fine. What you're going to see is tests that are very exciting, like one that we invested almost $500 million into. This is the Q test. This is almost a laboratory PCR level system with results almost as good as the laboratory-based PCR that can now be point of care. This was used for the NBA bubble, and as I said before, if it's good enough for LeBron, it's good enough for anyone. This is actually the reader. This is a disposable cartridge. You literally put the cartridge in the reader. It comes with its own swab, which they don't call a swab, they call it a wand. You swab yourself, put this in the reader, all the way in, you put it down, and within 15 minutes a result comes to your cell phone, and this is almost as good as the best PCR assays. This is a molecular amplification device. But I just want to show you that PCR has its role, antigen has its role, and we're using this, for example, with CHOP in many of our school systems, because if we get an unexpected result from the Binax card or another point of care test that we're screening millions of people with, we can go right to a point of care test like Q that is almost the same quality as a laboratory based like a PCR. So again, I'm glad you wound me up and got me started on this. PCR is an excellent test, and thank God for all the labs who are doing them, the public health labs, the ACLA labs, the academic labs, the hospital labs. They are the most sensitive. But if you want to know who's infectious and really stop the public health challenges, you really need simple tests that show who's infectious and who's not. And that is really the Binax, the Illum, the Quidels, the BD Veritors, that whole class of tests. And again, finally, we have a whole new class of those tests that are sort of right in between, that we could almost get the best of both worlds. The only problem is this is not high throughput. I can do hundreds of tests on a Binax just myself during a day, but these take 15 or 20 minutes per sample. So this is not a frontline test. It's still a backup in the milieu. But thanks for asking that. Really appreciate it. Next question.
Our last question comes from Sasha Pesnik with ABC News. Go ahead, please. Your line is open.
Thank you, Admiral, for taking my question and echoing my colleagues that really appreciate the briefings that you have been so generously availing yourself to over these months. In light of the events that we saw at the Capitol yesterday, we have seen several resignations from the administration, understanding that it is more in the national security sphere than public health. But in light of those, are you planning to stay in your post through the inauguration?
I am planning to stay in my post through the inauguration. As I said up front, I am deeply disturbed by what happened yesterday, what I saw outside my window, the flashbangs when I exited the door. But I'm a clinician, I'm a physician. I have a job to do. I'm sworn to do that. Almost 4,000 Americans died yesterday. Thousands more will die this week. I do believe I have an overriding duty to continue my role to support the COVID response and also to support the smooth transition to the Biden administration. So I will resign as the administration changes. That's effective at the end of January 19th. And I intend to continue to do everything I can, as well as I can, for as long as I can, and to make sure that the Biden administration, Mr. Zients, Ms. Johnson, and everyone on the transition team working on their task force is in as good a shape as possible. Was that the last question? Okay, well, thank you very much, everyone. Again, thank you for communicating all these important public health points to the public. And as always, you can always contact us through MIA if we need any follow-up. Thank you very much.